Hello, everybody. Good morning from Singapore once again, and good afternoon, good evening, depending where you are. I am Santiago Brandt, and I'm a clinical and sports psychologist, 17 years experience in the fields of neurofeedback, biofeedback, and brain mapping. And I'm very happy to be once more here with you to talk about identified indicators of trauma, talking about neuromarkers in the EEG. And the course objectives for today, we're going to discover the latest research in trauma markers. We're going to talk about what the latest papers talk about in terms of finding biomarkers and neuromarkers in the EEG. That will help transform your approach to mental health, hopefully. And then how trauma impacts the EEG and what we look for in the EEG to understand how the client is feeling and then how we can help that client, that patient, move forward to empower them. And lastly, we're going to use trauma markers to enhance our care. And as it pertains to neurofeedback, how we're going to use those markers to create specific, individualized, and personalized protocols for neurofeedback for brain training to optimize the well-being and mental health of our users. So with that in mind, let's get started.
Well, the first thing we need to understand is what is trauma. And it's very important because the trauma experience is different for everyone. There are some general descriptions of trauma from the APA and from authors, from different authors, and they all convey it to the same point to some degree, in which there is an emotional response to an event which threatens your well-being or your life. So you have the possibility of being seriously hurt or dying. There's a large and diverse cascade of reactions, which are physiological, psychological, emotional, and this manifests different from individuals. And so we use all this info to understand the individual's experience as it pertains to the trauma. As a clinician, that's important to understand because my perception of trauma will not be the same perception of trauma that the client experienced. Even if the client and I have experienced the same traumatic experiences, have gone through the same traumatic experiences, the way we understand and react to those experiences, it's different. And so we take the experience of or the diagnosis of trauma or PTSD as a general construct, and then we dissect it into different pieces to understand how we can help this individual cope and heal more efficiently. The bottom line is I have experienced something that threatened my life, or I have witnessed somebody being hurt seriously. Because not all the time a client will be the direct recipient of the trauma. They may have witnessed one parent hurt or kill the other. They may have experienced a terrorist attack, a natural disaster in which other people were hurt or unfortunately killed. There are some common reactions that are associated to trauma, and there are 4 distinct patterns that a client will experience. To me, this is a very important point here because normally they manifest during the first appointment with the client. When they call you on the phone, when they come see you and ask for information about QEEG brain mapping, when they're going to start the intervention process, it's very important to understand how these 4 components of the trauma response manifest for the client. And they are difficulty regulating their emotions, such as hypervigilance or hypovigilance. There's a numbing or a dissociation, a depersonalization. They will somatize, meaning they will express the trauma through some medical or physiological symptom, such as headaches, autoimmune conditions, hair pulling, nail biting, you name it. There are different manifestations of how the person is manifesting through their body, their behaviors, that trauma response. There's going to be helplessness. The person will come to you having tried many things before, and they tell you, you are literally my last option. If this doesn't work, I don't know what I'm going to do. If this doesn't work, I'm just going to give up. If this doesn't work, I'm going to hurt myself. And therefore, it's very important to understand In the EEG, you can pick up traces and patterns that would indicate which one of these four components is the dominant one for the client. Normally, clients present with all four of them in varying degrees of severity. However, one or two normally is or are the more salient ones for the client. For some people, it's the hypervigilance. For some people, it's the dissociation. For some people, it's the helplessness. For some people, it's the suppressing of the emotions. However, that's important to understand because that will drive the intervention and it will give you an idea of how smooth or how difficult, how challenging working with this individual will be. Now, the other question we need to ask is, does trauma leave signatures in the brain? Well, yes, it does. We see it all the time. We see it especially when we do EEG and QEEG. EEG and quantitative electroencephalography, which we also call brain mapping, which is those squiggly brainwave patterns. What's important to understand here is that not all of the individuals who have experienced trauma or witnessed trauma will have the same biomarkers or neuromarkers in the brain or even same response. However, looking at the EEG helps us connect the dots. Somebody with a traumatic experience can come to you as a clinician and ask for help with anxiety, which they have not linked to the trauma because maybe they don't feel they have been traumatized or they have experienced trauma. Sometimes they will come with asking for help with depression or consulting for sleep problems, which may be linked to a traumatic event. The reason why we look at the brain is because it helps us connect the dots and help understand this person's biography, their life story, and how it relates to their symptoms and their behaviors and their experience and the reason why they've come to us asking for help. However, the research shows that yes, there are changes in the brain as seen in EEG, MRI. So it will shift your brain function, it will shift your brain structure, it will shift your connectivity. And therefore, we need to understand how that's happening, why that is happening, how it is manifesting for the client, and how we can help it rewrite their history. How we can help them rewire the brain, optimize brain function, stabilize brain function, so that way they can heal and move on with their lives. And of course, there will be some brain areas that are involved in this, the amygdala and the hippocampus being one of them, or two of them rather. These are not the only brain structures that get impacted with the brain, but they are two of the structures that receive and store a lot of your trauma history. The amygdala, particularly being your guard, your the region structure of the brain that helps you scan the world for threats, understand danger, remember danger, associate certain elements and stimuli in the environment with danger so that you can be on guard. The problem in people with trauma and or PTSD is that the amygdala gets highly activated and starts making us see the world as a threatening place all the time. So individuals with hypervigilance, individuals with high anxiety, individuals with some degree of paranoia that is not necessarily psychotic, but that is trauma related, will see the world as a threatening place essentially 24/7. They're going to be constantly scanning the environment for threats. They have trouble trusting to other people. They have trouble relating to new people because they see them as a threat. So they're sizing people up, they're sizing the environment up, looking for threats. And obviously, that's not a fun, happy, healthy way of living. It really is. This individual struggle through life because they have trouble relating, they have trouble letting their guard down. The brain has wired itself for survival, and it's just creating a loop, a closed circuit that doesn't allow the person any flexibility for coping or healing. And then the hippocampus gets highly impacted. That's your memory center, is where you make new neurons. And when there's high like anxiety because of a trauma response, you get more cortisol circulating in your system. The cortisol will permeate the blood-brain barrier. It will go into the hippocampus. It will bind to receptors in the hippocampus, and it can cause cell death. It impacts your memory and it kills neurons, and that's not good for you. One of the main adjacent symptoms of trauma is memory loss. Many, if not all, clients who've experienced trauma will come to you complaining of memory loss. They will not say, I had trauma first. They will say, my memory it's very bad. I'm really concerned. And if they're in the age range for dementia diagnosis, the highest concern is that they have Alzheimer's or frontotemporal dementia. You scan them, they're good. They don't have any structural damage to the brain, but they still worry. And then when you ask for trauma history, things come together. So it's always the cluster of symptoms that the person is experiencing. We need to connect dots to help understand how things relate to each other. Let's see then some markers of trauma in the EEG and see what this looks like. So we look for biomarkers, neuromarkers. And essentially, this means that a brain signature that the brain creates, that is like a fingerprint or evidence of residuals. Just like when you go to a crime scene, you look for blood, you look for fingerprints, you look for dirt, you look for anything that points to the perpetrator. We do the same with the brain. In some people, when they have been traumatized, the brain will create a set of specific brainwave patterns that repeat themselves over and over again. And this relate to symptoms or diagnoses like major depressive disorders, anhedonia, sleep problems like insomnia, negative affect, irritability, volatile behavior. But many times again, when the client comes complaining, they don't complain of trauma. That may be the generator of their symptoms, but they either ignore it or they just don't know it because the other symptoms are more salient, are more present, are more debilitating. So that's what we look for, and we help them make the association, and we help them understand the situation at a deeper, more meaningful level. People with avoidance, who avoid and escape situations, may experience or may have experienced or may be currently experiencing trauma, which would explain that. And where do we look for the clues? In the EEG and the QEEG. Okay. In my experience, I have not discovered, so I'm not claiming I've discovered, I just have identified, and through mentoring with other people like Jake Unkelman, Linda Walker, and many others, have come to understand that these biomarkers, these signatures, are related to the trauma response. And that means if I see them in the EEG, the first thing I'm going to ask is for trauma history. Now, many times the client will say, trauma? No, I don't have it. I haven't had any trauma. And that's because normally people think of trauma as PTSD from being a war veteran, so being in a war zone. And if the person hasn't served in the armed forces, in the military, of course, they're not going to think they have any trauma. People think of trauma as sexual abuse. And if the person hasn't had any of these really severe experiences, they're not going to think they have trauma. But trauma could be something like, I was 5 years old. I went to the dentist. The anesthesia wasn't working. They went to do the procedure and it was very painful. I had a fracture. I broke my arm when I was 10 years old. I saw my dad come home drunk and berate my mom. So people don't relate those experiences. And therefore you have like a good detective to ask and ask and ask and essentially interrogate the client for many hours at times to get to the bottom of things. Because again, people don't relate those things as essentially or necessary or meaningful. Or sometimes people will try to avoid talking about these experiences as much as they can. So it's very important to ask for this. And some of those biomarkers include excessive beta activity, beta spindles, which can be localized or generalized, lambda waves, mu waves, the T6 infamous alpha marker, functional connectivity patterns, and of course, other patterns and comorbidities. Well, these are some of the ones that I've been able to identify and use as a tool to help the person come to terms and sometimes confess so we can help. So The first one I want to speak about is hyperarousal patterns increase high beta activity. Normally, when I teach, what I tell people is brain waves and EEG patterns in the brain can be both good and bad, but they could signify both good news and bad news. And the difference is in the time and the duration of these events. So if something is too repetitive in the brain and it lasts longer than a specific period of time, it becomes problematic. The more you see a pattern in the brain, the more intense it is, the more repetitive it is, and the more it lasts in time, the longer it lasts in time, it's problematic. And then I use a formula that I tell my students and mentees and colleagues, which is you take the client's age, you add brain region, brain location, the age and the gender, region, activity, and that equals your symptom and your behavior. So client age and gender plus the brain region plus brain wave pattern equals behavior and symptom. And that helps you understand how that is manifesting for the client. Hyperarousal, hypoarousal, aggression, depression, anxiety, OCD, you name it. That's the formula that you use. Now, sometimes I will see those beta spindles more present at F3 and F4. Does it happen for everybody? No. Sometimes they're everywhere. But it's a very clear and persistent pattern that creates lots of hypervigilance. These are the individuals who are highly hypervigilant. They cannot sleep at night. They cannot form and sustain meaningful relationships because they're weary of people's intentions. They see the world and they perceive the world as a threatening place where everybody's out to get you. And you can see those little owl eyes with a very distinct pattern at F3 and F4 in the QEEG. And this is what they would look like in the EEG. It's very persistent, as you can see. Sometimes they're high amplitude. So the voltage output is higher, which means the condition would be more severe. And the first thing you need to rule out is a medication effect. When you get beta spindling, you need to rule out medication effect. So if it is not a medication effect, then it means there's hyperexcitability and very likely neuroinflammation. The neuroinflammation can come from different things. It could be viral, it could be bacterial, it could be metabolic, it could be environmental, but you need to send them and refer them to a specialist who can assess for these things. In my experience, 8 to 9 out of 10 patients who had excessive beta spindles that were not medication effects had some form of neuroinflammation and dysregulation in their metabolism, which warranted medical attention. So it's not always in the brain, it's also in the body. What it is in the brain, it's in the body, and what it is in the body is in the brain. That's the relationship. If it is happening in your body, it's affecting your brain. If it is happening in your brain, it's affecting your body. And therefore, we need to understand that relationship and work with it. This is, again, the hypervigilance pattern. And this is what it would look like in the QEEG. So you can see that this individual has very highly distributed beta and fast beta activity, high amplitude in the topoma, centrally located, but also when you go to Loretta, you can see that depending on the orienting and the location of the dipoles, you can see other generators, your temporal lobes, your temporal parietal region. And again, this helps you understand how you're going to work with that brain. Your decision making is more efficacious, I would say. It helps you decide where you want to train and what you want to train for how many sessions, with what intensity, and what interventions you will combine. The other one is the lambda waves. And surprisingly, in current trainings, we don't mention lambda waves often, but they are quite prevalent. I don't have exact statistics, and you will, when you see this webinar, you will see a list of research articles, all the research and the references, and you can read those. Probably you'll get some more specific statistics as to what the lambda waves are, what's the prevalence in the population percentage-wise. Nonetheless, they're present in individuals. And the first thing I think when I see lambda waves is PTSD. Normally, the individuals that have lambda waves end up meeting the criteria for PTSD. So it's not only trauma, it's a PTSD diagnosis. And that's quite significant because then you can also refer for further analysis, further assessment, and then start working depending on what the client's needs are. Now, lambda waves occur in the eyes open condition in the occipital region of the brain. In the QEEG, they will look like alpha. Just like mu waves, lambda waves are part of the alpha family, it's an alpha variant. And it normally means that there's eye fixation. Not all the individuals are fixing their eyes will make the lambda, but it's eye fixation, and it also corresponds or correlates to hypervigilance. These individuals are highly hypervigilant, very anxious, and very hypervigilant. And they look like the tip of a spear or a sharp tooth. So it's normally the pattern that you look for. They occur at O1, at O2. They normally fast frequency 11 to 12 hertz. So they tend to be really fast. And in the QEG, they will show up as fast alpha. You need to go then to the EEG to make the distinction through the morphology and look at the lambda waves. So their eyes are fixed, but their brain is laser focused on something that is potentially threatening to them and is potentially triggering them. And again, eye fixation, hypervigilance, trauma response. Normally, I would say 70 to 80% of the cases, based on my experience, they meet the criteria or end up meeting the criteria for PTSD. But this is another pattern you want to look for. Once you see the lambda, first thing you're going to ask is any trauma history. If the client says no, you need to keep asking. And sometimes the client doesn't have to have trauma to have lambda waves. Okay. Sometimes the person will honestly say, look, I don't have any trauma. I just have a lot of anxiety. Okay, fine. But we need to ask because, again, 8 out of 10 times the person will meet the criteria for trauma response PTSD. They will deny it, or they just don't remember it. Or again, they're not associating their history, their events to trauma. And again, it looks like it would show up like alpha. In this case, it's a little slower, 9.28, but it tends to be faster. And you want to also go to the Loretta maps because you want to see specific generators. Sometimes you will have something showing up in a specific location. Once you do the Loretta, you look at the difference between the distribution of your dipole voltage difference. Then you can look for a more specific generator, which means you can be more specific with more pinpoint accuracy, target a specific area or areas of the brain. The next one we have is mu brainwaves. Now, we have to have a word of caution here. When we see mu in the brain, when we see mu in the EEG, we really need to take it with a grain of salt because mu, like the other brainwaves, can mean good things. It could be good news to the client, and it can also mean bad news to the client. So once you see the mu, you don't automatically think trauma. You can ask for it. Mu is picked up in 70% of the people with autism. So your autistic population, 70% of them will present with mu. And therefore, the first thing I suspect and I ask for when I see mu is ASD, autism spectrum disorder. Okay, I will observe their behaviors. I will ask the parents. I will talk to the client. Many times they already come with a diagnosis of ASD. They will tell you, I've been diagnosed with autism. I just want to confirm that that's the case. Will the EEG help me understand myself better? You will say, yeah, we will look for patterns. We don't necessarily diagnose with the EEG, QEEG, but we'll look for patterns and correlations. And then you see the mu. The mu is 70% present in ASD. It's about 30 to 35% in ADHD. Can it be present in somebody with ASD and ADHD? Yes, there can be comorbidities. Could it be present in a high functioning autistic individual? Yes, it can. So you have to really talk to the client at this point, and you really need to help them understand the situation. Okay. So you see the mu. You rule out autism, you rule out ADHD. Mu, it's also seen in peak performers. So athletes, singers, fighter pilots, SWAT, elite forces, Navy SEALs, surgeons, anybody with a skill set and a specific talent sometimes will have mu in the EEG. Not all athletes have mu. Not all SWAT or Navy SEALs have mu, but some of them will. And that's good news because that's their innate peak performance state. In these individuals, I like to call mu a positive dissociation state. Positive dissociation as they get into the famous zone. They get into the zone and they can flow and perform in the midst of all distractions and pressure. So these are the guys you send overseas for very dangerous missions because they're calm, cool, and collected under pressure. And some of them have psychopathic traits. Some psychopaths also have mu in their EEG. So again, a point of contention here, you need to ask, okay, if it is related to trauma, normally you can also pick up beta patterns. And I didn't box them here, but you can see some fast beta around mu. And this is a hypervigilant line. And then the mu is a dissociative pattern. Mu in trauma people means dissociation, depersonalization. These are individuals who dissociate and depersonalize as a consequence of their hypervigilance. They have learned to survive by numbing themselves, disengaging from the world, disconnecting from the world. In cases like that, then use a dissociative pattern. Do you want to break that dissociation? Yes. Will you need to? Yes, it's a must. Because the dissociation is a survival adaptive response, just it's not a healthy one. You're going from hypervigilance to dissociation and you keep in that pattern, you cannot function well in the world. You can try to function well, but realistically, you're not going to function well in the world. And so we need to find ways of breaking that. And you can see the mu being present in this, for this individuals, you can see it's also affecting the right side of the brain, impacting the right insula. So it's not only the sensory-motor region, it's your mirror neuron system, is your insula, which makes you more volatile, more reactive, more depressed. If you have suicidal ideation, it exacerbates your suicidal ideation. If the client is experiencing paranoia, it exacerbates your paranoia. If they're experiencing depersonalization, it exacerbates the depersonalization. So when you have other areas of the brain that are dysregulated and you have the mu, you have the exacerbation of that dysregulation. So it's, in essence, is more dangerous for the client. Then you really need to target that rather quick and aggressively. The other one is the infamous temporoparietal alpha. There's a paper called The Electrical Aftermath. If you go to Google Scholar and you search for the electrical aftermath, it's a paper that has identified the T6 alpha marker as a marker for trauma or PTSD. So it's been published. And what you end up seeing is a larger field like the mu, it's just very high amplitude alpha over at T6. Okay. It normally means this trauma or the individual will meet the criteria for PTSD. It affects your social affective relationships. So it affects the way you relate to other people. Individuals with this biomarker have difficulties trusting other people, have social anxiety, have trouble relating to other people, meeting new people, interacting with other people in social settings. But it could also be a marker for intergenerational trauma, meaning the trauma has been inherited by the individual. They haven't experienced it, but they inherited it. A very clear example is this one. This is the EEG, or the spectral display of an EEG of a colleague of mine who I did the brain map for. She's from Austria. And when I saw this, you can see the P4, P8. So a lot of people will have only the alpha peak here at T6, but a lot of people, or a high percentage of people, I should say, would have both. And again, is social affective, relating to people, social anxiety. When I asked her for trauma history, she said, I don't have, but my grandmother is a Holocaust survivor. My grandmother survived the concentration camp. And if you read the work of Robert Sapolsky, he talks about how trauma and stress can be inherited. There are studies in the Netherlands of grandchildren of Holocaust survivors who have inherited autoimmune conditions due to their grandparents' trauma. When the grandparents were starved and were put through hard labor in the concentration camps, they developed specific metabolic responses. The body reconfigured itself metabolically, and the grandchildren ended up inheriting this. So there's a group of people in the Netherlands with autoimmune conditions and metabolic disorders who are the grandkids of Holocaust survivors. So again, now we see that you don't necessarily have to have experienced the trauma or witnessed the trauma. You could have inherited the trauma from your grandparents. And this also is the case of war veterans from World War II and Vietnam. So grandchildren are showing patterns of traumatic responses in the brain and in the body. Nonetheless, if you see the high peak, it's very high amplitude, and it really stands out from the rest of the alpha and the other frequencies in the brain, you can rest assured it's very, very likely, 99.9% very likely the person has trauma or meets the criteria for PTSD. And then you ask them. Some people, or most people rather, would show it in the eyes closed condition. And then another percentage of people will show it in the eyes open and the eyes closed condition. So it's there, either in the eyes open, in the eyes closed, or both. And again, you can do your Loretta to show what you have, what it shows like in your brain and your topo maps. There's increased theta activity that's related to trauma as well. And normally this increased theta activity shows up frontally, which you can also diagnose or understand as OCD. In addiction, 1/3 of the addicted population has OCD, obsessive compulsive disorder. I don't know the statistics exactly, but I would say a percentage of the population with trauma, PTSD, will also meet the criteria for OCD. And in our work with EEG and QEEG, it's always a chicken and egg problem. Which one was first, right? Was it the PTSD or the OCD? Or was it the OCD that's causing the PTSD? Irrespective of that, I think what's important to understand is we have a pattern that we need to correct, that we need to stabilize, that we need to optimize for symptom mitigation, symptom elimination. But some individuals will present with that excessive frontal theta. And remember, excessive means it's long lasting, more than 1 second in time, and repetitive through the EEG. It's your clue. Once you see a pattern in the EEG that gets your attention, now you really fix your eyes on it. You're going to peel your eyes and you're going to follow it. If it happens once, twice, 3 times, and more, and it's longer than 1 second in time, it's a problematic for the gamma waves, for the mu waves, for the alpha waves, etc., etc. So we have research, published research, that shows that theta excess, theta presence, theta intensity, it's also correlated with hyperarousal patterns. And these hyperarousal patterns can be sometimes traced to trauma history in some individuals. Well, again, you do ERPs, you do MRIs, you do EEG, and you correlate. So this study here by De La Rosa and collaborators looked at hyperarousal symptoms by looking at certain images, neutral images, and threatening images. And the people with PTSD react essentially the same way to both. People without trauma, when they look at the neutral images, they don't have much of a reaction. But the people with PTSD will react to a tiger, to a rifle, to a war zone image, the same way they react to seeing puppies. So it's their amygdala and their limbic system is more hyperactivated. And these are the people who are looking at the world as a real threat. Cute little puppy is a threat. Cute little baby is a threat, a potential threat, I should say. And so It's just how their brain reconstructs their experience of the world, which we need, again, to understand specifically. And then we have functional connectivity. Trauma will impact and dysregulate the way your brain talks to itself about itself and how the brain relates to the outside world. There's a reconfiguration of your connectivity and your neuroplasticity through trauma. Once you're traumatized, you will never be the same person again. That's realistic. I've had trauma myself. I've experienced traumatic experiences myself, and I haven't been the same since. Now, am I coping better? Yes, I am. Have I helped myself? Yes, I have. But once somebody experiences trauma, it's really important to understand that they're never the same. They don't have to feel broken. They don't have to feel sick or crazy. And it's just to help them understand that now we need to refurbish the plasticity. Okay. The EEG and the QEEG help us understand through coherence maps, through phase maps, how different networks of the brain are talking to each other. And what's important to understand is to help the individual understand how their experience or experiences have rewired the brain for survival, and their symptoms are nothing but the expression of their survival mechanisms. It's not because who they truly are. It's not because they're crazy. It's not because they have bad karma. It's just because trauma rewires the brain. And now we can help them with these other experiences, with neurofeedback, with photobiomodulation, and so on and so forth. And therefore, it's important to understand that when we work with individuals, we work with them from the psychological perspective through cognitive and emotional work, cognitive behavioral therapy, other forms of psychotherapy, but we also have the psychophysiological, and we need to combine what happens in the neurophysiological patterns for the brain, the psychophysiological patterns for the body, and how they end up reacting emotionally and cognitively. All interventions need to combine both. I would say that they must combine both. You can reduce the arousal, but you need to teach the skill. And you cannot teach the skill unless you have reduced the arousal. So again, working with both in a combined manner is more efficient. And I say this because many therapists that I have interacted with in my career are either too focused on the cognitive behavior or too focused on the neurofeedback and biofeedback. More and more are seeing the importance of the integration now, but we still need to help people see the importance of integrating these things. And we can do this by training different psychophysiological signals like muscle, respiration, skin conductance. So these are more the biofeedback related, and biofeedback is an incredible intervention. One of the different modalities is heart rate variability. And in heart rate variability, we're essentially teaching the heart and the brain to talk to each other, be friendly to each other, be loving to each other, because when you enhance the relationship between your heart and your brain, powerful things happen for you in terms of your healing capacity. Let's look at this case study. This is a client who had traumatic experiences. He worked in construction. And one day where he was working, there was an accident and a colleague of his got severely injured. He almost passed away and he experienced this. And in his brain, we were picking up new. So he had a dissociative pattern. He had to learn to dissociate at work and in life to cope with this experience. Now, this is only a 5-minute breathing session, mind you. So this is just an example. It's not a whole course of intervention, but it's just to show how 5 minutes of deep breathing, coherent breathing, can make a difference. What we see here is the mu. And this is the point where the client starts engaging in the coherent breathing. So I taught him how to breathe, and he did this for 5 minutes. In those 5 minutes, he was able to desynchronize the mu, which means he was breaking the dissociation, which means he was becoming more present, more mindful, and operating better. Imagine if this is only with 5 minutes, what doing this for a course of sessions will do. And we have the evidence because we're recording the EKG and the EEG at the same time. So we have the objective, visual, tangible evidence that this works. And so we started the intervention, and this individual ended up doing a lot better. Now, we can use biofeedback, And we can use heart rate variability biofeedback, skin conductance biofeedback, temperature biofeedback, or we can combine all of this. And if we add the neurofeedback to the equation, well, even better. This is a male client with traumatic experiences. And in the EEG, what I found was the T4 elevated alpha plus lambda waves auxiliary. T4 elevated alpha is the insula. This is an individual with extreme anger, extremely irritable, extremely volatile, and easily triggered. Okay, so the T4 alpha was impacting the insula, which was causing his rage and his reactivity. He was verbally abusive to his wife. So we started doing the neurofeedback, and around 30 sessions, he asked if we could do another brain map because he was feeling different. And I thought that was a good idea. So that's what we did. So the client reported feeling less reactive, less depressed, and the spouse, the wife, reported a noticeable reduction in verbal abuse. She was saying he's not as aggressive, he's more calm, he's not triggered easily, he now thinks before he says things. And this is what we see. This is the EEG at baseline, and this is the EEG, the eyes open, after 13 sessions of neurofeedback twice a week. So the protocol was a CZT4 bipolar 1 channel, active electrode over CZ, the reference electrode at T4, the ground electrode over the left ear. And we were doing 0 to 30 inhibit, 12 to 15 reward. So we were inhibiting the low and high end, and we were in the 12 to 15 range. And this is what you see. This is the high amplitude alpha, and look at the desynchronization. Now, this is just a sample, but this happened throughout the EEG. And this is what the topo maps look like. This is the alpha, very specifically located at baseline, and after 13 sessions. Normally, I would do 20 sessions and remap, but a little bit over halfway through, he was interested in doing that. Then you start seeing the evidence. He was responding very, very well to the intervention. And that ended up saving the marriage and saving his life potentially because he had suicidal ideation at some point. Now, this is another interesting one. This is a male. He was adopted from a Russian orphanage by an American family. They live here in Singapore. The mother and the father are American, and the kid was adopted from a Russian orphanage. So what did we see? FZ, elevated theta, oppositional defiant disorder, suicidal ideation. He was 14 when I was working with him, and he reported high suicidal ideation. We saw mu waves and parietal P4 alpha. So all of your indicators of trauma plus other things, okay? And what was the treatment plan? I focused on CZT6, bipolar 1 channel, FZ to the linked ears, the CZ to T6 to work on the trauma response, FZ linked ears for the OCD and the suicidal ideation, and F3, F4 for reduction of the hypervigilance and also the mirror nervous system. So we did around 100 sessions total, and I did a queue every 20 sessions for control purposes. So this is the EEG at baseline with some clear markers, the mu, the T6 alpha, and then this is the frontal FC theta. So this is his brain at baseline, and this is the brain after 40 sessions. Look at the activation of the anterior cingulate cortex, the P4 alpha, and you can see a great reduction in activity from baseline to 20 sessions. And again, we did a total of 20 sessions. One of the clear behaviors and distinctive behaviors of his OCD was that he could not eat with his hands, and he could not watch people eat with their hands, chips or Cheetos or things that you normally eat with your hands that would induce vomiting. He would be grossed out and vomit. And after 100 sessions, he was eating with his hands. He could watch people eat with his hands, and he was no longer reporting suicidal ideation. So this is another example of how we can use the EEG and the QEEG to identify the areas of the brain we need to train, and we get results. Now, good news, because since 2023, the FDA has approved some neurofeedback technology for PTSD work. So that only helps increase our credibility. Now, this is the MCI from the eye medicine system, the dry helmet from Korea. And the MCI is the predictor for mild cognitive impairment. So they have metrics for people over 50 in which you can basically measure somebody's percentage probability of developing dementia. So in their metrics, anything over 50 puts you at high risk for dementia, specifically Alzheimer's disease. And this is somebody who was scanned and they were at 50%. So they were already high. In the week that we scanned them, they got into a car accident. And we scanned them again after the car accident, and it probably went up to 64.3. So it just goes to show how trauma severely and very rapidly and very quickly impacts the brain. So they are at high risk, that they're over 50, and in the course of a week, how things changed. They probably have more cortisol and inflammatory cytokines circulating in the bloodstream and attaching to certain parts of the brain. Well, now things are really bad. So we need to intervene very quickly. And this is from the SOCOM in Tampa, Florida, a military base that Dr. Tom Halter works with. And he has kindly provided the maps. So these are topo maps of soldiers with PTSD, veterans from the US with PTSD. And you can see all the red shows the excess activity. And this is an individual at baseline without PTSD. This is an individual with PTSD. The more red, the worse. And we can look at the markers as well for that. So we can do database comparison and whatnot. We can look at connectivity maps. So in people with excessive hypervigilance, you can see the red, and the red lines here mean the hyperconnectivity. We can look at the topographic and the connectivity maps, and that gives us an idea where they stand. And we can use photobiomodulation for that. So I'm not going to stop here too much. You can read a little bit more about photobiomodulation, but we just want to show you that we can impact the brain severely with that. And mainly because the photobiomodulation, what the photobiomodulation will do is reduce the inflammation in the brain through the creation of more BDNF secretion, neutralizing inflammatory cytokines, and so on and so forth. And with this, we have been able to really see powerful results. What I've seen lately is that when people combine photobiomodulation, they do about 30 minutes of photobiomodulation, immediately followed by neurofeedback, they get results more efficiently, more quickly, and they're longer lasting. These are some PBM protocols that we use with the eye medicine system created by Dr. Debbie Kim out of Los Angeles. She works with the system and she kindly shared this info. These are protocols that she created for different conditions. If you want to optimize the brain, if you want to do deep relaxation, you can do local training. And iMedicine is a company that is really, really working on research, and they're doing present research in different countries here in Singapore, in South Korea, in the United States with stroke recovery, with autism, with PTSD, with traumatic brain injury. So they're gathering really, really well done, really well performed research that is going to be published with a PBM. And so I recommend photobiomodulation as a form of intervention. Having said that, I would like to open the floor for any questions that people may have. Thank you, Eunice.
Yes, I think you have an Instagram page. And
Yeah, let me type it here. My Instagram is Neuro Santiago.
no wonder I couldn't find it.
Neuro Santiago is my Instagram, and then my YouTube channel is Santiago Brand.
He has a lot of other videos on there that are very educational and very cool to look through. I've been on there a couple of times. So I had a question. So for example, if a client comes in and is having severe dissociation where they feel like their body isn't real and they feel like this is an alternate I guess maybe an alternate body that they're in, that's not their real body. Like, would neurofeedback and PBM be helpful in those cases? Like, how severe can someone's trauma be for the neurofeedback and PBM to be helpful?
That's a very good question. The first part of the answer would be it's important to understand that in some of the cases, neurofeedback and for biomodulation may not work. Again, from my personal experience, in about 1% of the cases that I had where dissociation was the salient symptom, I was not able to help them with neurofeedback and biofeedback. I did another form of intervention called brain spotting, which I found very powerful and very helpful. Now, dissociation is very hard to break. It's tough to crack. And to help with dissociation with photobiomodulation neurofeedback, the first thing you need to do is understand their arousal and work with the arousal because dissociation is a byproduct of the hypervigilance. And the more hypervigilance, the more hyper aroused an individual is, the more they dissociate. So the first thing you need to help them is to safely and comfortably guide them to reduce the hypervigilance. It's quite ironic because people come to neurofeedback for help with the anxiety and the hypervigilance, and the moment you start reducing it, they resist it. But they do, it's because that's all they're used to. That's all they know. And many clients would tell me, it feels so strange to feel relaxed. It's scary to feel relaxed. I was so used to my anxiety that in the beginning, when I was feeling relaxed, I would get scared. I didn't know what to do. So you have to gradually reduce the arousal to the point they feel comfortable dealing with it. And then that helps break the dissociative pattern. Sometimes you make the mistake of targeting the dissociation directly. For some individuals, it might work. For a lot of them, it doesn't because you have to bring down the arousal. With the photobiomodulation, you start with very low intensity for 2 minutes, 5 minutes at a time, and then you work your way up. With neurofeedback, you do the same. You start with a short session for a few minutes, and you have to work with the client's window of tolerance, meaning how much of the session they can withstand. Heart rate variability biofeedback is very helpful in this case because it's a non-invasive form of intervention. And when people learn how to breathe, when they remember how they should breathe, it makes the process easier. The bottom line here is for dissociation, you have to work with the arousal and you have to work gradually. And it may take a great number of sessions. I mean, for some people, 100 sessions, for some people more, for some people less. But you have to understand how to lower the arousal comfortably and safely so um, they don't react and they don't upreact. So thank you for the question because it's very, very important.
Mm, thank you. That was a very good answer. Thank you, everyone, for joining us.
Well, good night, everybody. Bye-bye. Thank you.
Bye.